Hi, everyone. Welcome back and welcome to the third and final session of Mini Medical School Mind Matters, Brain and Mental Health. I'm Katie Cullen, and I'm a professor in the Department of Psychiatry and Behavioral Sciences, and I'm also the director of the Division of Child and Adolescent Psychiatry and Mental Health at the medical school. So happy to be here, and I'm very excited to have you join us. We're going to guide you through our final topic in the series, which is the aging mind, navigating mental health in later years. So what we're going to do is we'll begin with a moderated discussion followed by a question and answer session. You can submit your questions to our panelists at any time using the Q&A box, which you can find by clicking, which is down at the bottom of your Zoom screen. There's a Q&A button there. And please note that the session is being recorded and will be available starting tomorrow at the Office of Academic Clinical Affairs YouTube channel. And we'll share the link with you by email. So today we have the privilege of speaking with a panel of experts to help us understand the impact of cognitive health and delve into strategies for promoting mental resilience. So without further ado, let me introduce our panelists. I'll first bring in Dr. Joseph Gogler. Dr. Gogler is the Robert L. Kane Endowed Chair in Long-Term Care and Aging in the School of Public Health and the Director for the Center for Healthy Aging and Innovation. His research examines the sources and effectiveness of long-term care for people with Alzheimer's disease and other chronic conditions. So Dr. Gogler, could you discuss dementia, Alzheimer's, and promising treatments for us?
Sure, would be happy to. Again, always great to be back at the University of Minnesota Mini Medical School. I will share my slides and we'll kind of get right into this. So today I'm going to talk briefly about Alzheimer's, dementia, and treatments, both current as well as those potentially on, not only potentially, actually those that are emerging and really as of the past year and a half or so. I have no conflicts of interest to declare. So I always like starting this presentation or similar types of presentations, first differentiating between Alzheimer's disease and dementia. It's a question that is often posed. The terms Alzheimer's and dementia are quite commonly used interchangeably, but in fact, they're two different things. And the first thing is to think, what is Alzheimer's disease? And let's think about what Alzheimer's disease is in terms of the symptoms and what it looks like. First and foremost, Alzheimer's is a type of dementia. There are other types or causes of dementia that we'll be talking about briefly later, but it's a type of dementia that causes problems in memory, thinking, and behavior. It's in fact the most common form of dementia. Roughly 60 to 70% of all cases of dementia are caused by Alzheimer's disease. This third point I really want to emphasize: Alzheimer's is not a normal part of aging. I think many of us have been around long enough when we've heard terms used such as old-timers disease or senile dementia, more or less referring to Alzheimer's as something that just naturally occurs if we get old enough. And in fact, that is not the case. Alzheimer's disease is certainly a pathology. It is a pathology that occurs in the brain. I think many of us have heard the terms, for example, plaques and tangles. Those are the neuropathological hallmarks of the disease. Plaques are essentially amyloid or protein deposits that collect outside of the brain cells or the neurons. And then neurofibrillary tangles are essentially tangles that damage the brain cells from within. And together, these are the two really biological or neuropathological hallmarks of the disease itself. And these are not normal. These are not normal processes that occur as we get older. Alzheimer's disease is certainly a chronic condition in that it worsens over time, and there is no cure at present. However, there certainly are many evidence-based approaches that can manage symptoms effectively, whether that be behaviors or other symptoms that are the hallmarks, the clinical hallmarks of Alzheimer's disease. And I really want to emphasize as well, and you're going to be hearing certainly from Dr. Cotton and Dr. Salisbury, many of the evidence-driven or evidence-based approaches to manage symptoms in dementia are not pharmacological. They're not all based on drugs or medical treatments per se. So then what is dementia? And it's important to note dementia is not a disease. It's really a group of symptoms. It's caused by damage to the brain cells. And as I had indicated, Alzheimer's is the most common cause. But there are other causes, for example, vascular dementia is the second most common cause. What characterizes dementia is people who have dementia start to have challenges or problems engaging or performing activities of daily living. Basically, those activities that help us remain independent. People living with dementia start to have problems doing these types of things on their own, whether it's getting in out of bed, in some cases eating, dressing, driving, managing medications. And so these all are, these impairments are present in dementia. Dementia is irreversible and degenerative, and often other illnesses complicate the severity as well as the progression of dementia itself. Now, again, I believe these slides will be shared to everyone who's attending today. I really love this graphic. It was shared to me, I think a couple years ago by a colleague out of the United Kingdom that really, to me, summarizes effectively what dementia is and how Alzheimer's disease or other causes of dementia are related to it. So again, dementia is this umbrella term. It describes a collection of brain diseases and their symptoms. The symptoms being memory loss, impairments in judgment, changes in mood or behavior, and then again, as I had talked about, the inability to perform daily activities. And here you see some of the various causes of dementia. We've already talked about Alzheimer's disease, vascular dementia, which again is disease or injury to the blood vessels leading to the brain. And then these other forms of dementia, which even though they still comprise a fairly small percentage of cases at present, they actually due in part to advances in our diagnostic approaches and techniques, have been characterized more frequently. And if any of you have known anybody, cared for someone who has lived with frontotemporal dementia or Lewy body dementia, these are very challenging forms of dementia to not only live with, but also to care for. You know, in frontotemporal dementia, which is characterized with deterioration in the frontal and temporal lobes, and those parts of the brain often control emotional regulation, inhibition, and thus behavioral challenges can be very significant and very severe in FTD. Whereas Lewy body dementia really is characterized by Parkinson's types of symptoms, you know, motor rigidity and such, and then also hallucinations, which again can be very challenging not only to live with, but also to care for as well. But again, this is the relationship, and this is how Alzheimer's disease and dementia are related, but are not the same concept. So the second part of Dr. Cullen's question dealt with treatments. And as of maybe 18 months ago, there really was not a lot of progression as far as treatments are concerned. When we think of pharmacological treatments, they're really, again, there is no cure for Alzheimer's, and there's two types of medications that at least to date have been most commonly prescribed. First, acetylcholinesterase inhibitors, for example, Aricept, for those of you that are familiar, and then Namenda or memantine. Namenda was the first drug approved to actually treat those in the moderate or severe stages of Alzheimer's disease. As a rule of thumb, these medications work for maybe half the people for maybe only a few years. They have modest effects, and by and large, they don't have really any discernible long-term impact on Alzheimer's disease progression, to the point where I would argue many people and families often utilize these medications for many, many years over the course of Alzheimer's disease or related dementias, leading to the question, not so much whether these work or whether you should take them, but when should you actually get off of these due to cost and really lack of effect? And that's a very challenging question. Many families, and in some cases, healthcare professionals tend to be reluctant in taking people off these drugs because there's this perception that, well, if I take my mom or dad or loved one off of, say, Aricept, they're really going to decline precipitously, and I don't want that. Again, it's a very challenging kind of conversation and decision to make. Now, As of really January of last year specifically, but even predating that in 2021 and 2022, there have been a new class of treatments that have received FDA approval, have certainly caused some excitement as well as some trepidation in terms of their potential. These essentially are anti-amyloid treatments. It's important to note these treatments are not drugs. They actually are infusion therapies. Many healthcare systems are getting prepared to actually offer these treatments to people living with dementia. And so again, what these treatments do is they actually stimulate the immune system response to reduce the accumulation of those amyloid plaque deposits that I talked about earlier. The thinking is because these again are key indicators of Alzheimer's disease, that if we can reduce their accumulation, it will help overall symptoms and improve overall quality of life for people living with dementia. The trials that have been done, they've raised some questions. Number one, they have been done over a 1.5 year period and have targeted people primarily with what is called mild cognitive impairment, or those in the mild stages of dementia. It is unknown what the long-term effects of this treatment are. Also, quite frankly, it's unknown whether these treatments are really going to have a significant real-world impact on quality of life, well-being, and function of people living with dementia. So again, these treatments certainly work in reducing amyloid plaque formation, but one thing we know is that for many people, those even people who haven't been diagnosed with Alzheimer's disease while they're alive, in some instances, people may have amyloid plaque formation in the brain, and they may not show any symptoms of Alzheimer's disease while they're alive. So again, putting all of our eggs in the basket of what's called the amyloid hypothesis, that being that if you can stop amyloid plaque formation, Alzheimer's disease can be stopped or slowed. There is some evidence for that, but it's not universal, I would argue. There are other questions as well. There are adverse effects to taking these treatments, specifically what are called ARIA, or amyloid-related imaging abnormalities. The most concerning adverse effect is actually brain bleeds. In an earlier form of anti-amyloid treatments, which is called Aduhelm, actually the drug maker no longer is making this actual treatment. There were actually a fairly a startling percentage of people who were on the treatments that had brain bleeds, which again is not an adverse effect that any of us would want to live through. The final point I would want to make about these new treatments is also the cost. It's roughly around $25,000 to $30,000 to deliver these treatments. Now, again, the Centers for Medicare and Medicaid Services, CMS, have approved payment for these treatments. That being said, for those who are on traditional Medicare, there still will be a 20% copay, roughly $5,000 to $6,000 out of pocket. For those who are on Medicare Advantage, and that really is most of us in Minnesota, it is unclear what those plans will do to cover treatment related to anti-amyloid, these new anti-amyloid therapeutics. One thing I would really recommend you check out if you have time and you're interested in learning more about these therapeutics, we actually hosted a really exciting panel of some of the leading experts, geriatricians, neuropsychiatrists, and others in the country, some of whom were actually involved in the original development and testing of these treatments. For example, Dave Notman at the Mayo Clinic. And we actually held an interactive question and answer session about these new treatments, what they mean, what we should be prepared for, whether we're family members, individuals living with dementia, or healthcare professionals. And again, if you have these slides, you can freely access both the slides as well as the recording itself. I wanted to conclude by emphasizing that much of the evidence that we have available in treating key symptoms in Alzheimer's or dementia, for example, behaviors, is in fact from non-pharmacological approaches, not from drugs or these new emerging therapeutics. And to really boil this down simply, person-centered care, valuing the preferences, valuing the personhood of someone living with dementia is core to ensuring quality of life and well-being, and oftentimes is an effective approach when managing behavioral symptoms. And unfortunately, the message hasn't necessarily been disseminated, I would argue, to many long-term care providers, to even healthcare professionals as well, where still the mindset is behaviors means we have to utilize certain types of medications to manage that effectively. And in fact, it is recommended by the American Academy of Neurology, the American Geriatric Society, the Alzheimer's Association, that the best strategy to address behavioral symptoms or other symptoms of Alzheimer's disease is, in fact, this suite of non-pharmacological approaches. And again, time does not permit me to go in each of these. But one really great, again, graphic I came across from my colleague in the UK that she shared was effective communication, for example, for people living with dementia. And of these 10 tips, the one I'd really recommend, and I think has been most helpful when working and talking with families, is point 8. Remember the 10 rules. Communication is core to person-centered care for people living with dementia. How do we effectively communicate with people living with dementia? Because even though maybe verbal skills and cognitive skills decline with Alzheimer's disease, emotional affect, use of touch, music, images is still an effective way to communicate with someone living with dementia. For example, always reminisce, never say remember. Always repeat, never say I told you. Always encourage, never say you can't. Always ask, never command. You kind of see the philosophy here. Maintaining personhood when engaging with and assisting people living with dementia. I'm going to conclude here with a really exciting policy innovation that's occurring that hopefully will bring many of these principles to bear in how we can best care for people living with dementia. CMS is actually going to be launching beginning in July what's called the guide model, where it's providing financial incentivization to healthcare providers to offer what is called collaborative dementia care, meaning that care is offered vis-a-vis a multidisciplinary team, a comprehensive care planning approach that must include a care partner, whether that care partner is a Medicare beneficiary or not. That's what makes this policy so exciting and innovative. We have known for many years, those of us in the dementia care space, that effective assistance to someone living with dementia goes well beyond a healthcare encounter. Most of the care is happening at home. And in that home, most of the care that's provided and overseen is often done by a family member, loved one, relative, etc. And if those individuals aren't identified and incorporated into formal dementia care regimens, the care provided often falls short. The guide is designed to ameliorate that. And because of time, I'm going to stop there. But again, we are in a very exciting era, not just for therapeutics in terms of drugs and infusions, but also in how we think about and care for people living with dementia. And I'll leave you with that.
Wonderful. Thank you so much, Dr. Gogler. That was incredibly informative and just really, really helpful. And thank you to the audience for bringing some questions already. That is wonderful. And we will be addressing questions in the discussion at the end. But for now, I am going to move to our next speaker, and I'm really excited to welcome Dr. Quentin Cotton. So Dr. Cotton is a Robert L. Kane endowed professor or postdoctoral fellow. His program of research draws on qualitative and mixed methods research methodology and examines 3 harmonious dimensions. Number 1, the influence of life events and trajectories on human well-being. Number 2, optimization of health and social service supports. And number 3, community level intervention design and implementation. So Dr. Cotton, how do we design communities to support mental resilience and healthy aging?
Thank you. That's an excellent question, Dr. Cullen. I'm so excited to be here with you all and to help move us forward in answering that question. My slides, are they being shown? I can't see them.
I think they will pop up soon. There we go.
Great. So during our time today, I will define mental resilience and healthy aging, discuss place as a contributor to health outcomes, and really kind of walk you on this journey where we review some practical strategies that you can apply in your own life, as well as discuss some community level strategies designed to protect us as we age. Let's go to the next slide. I have no conflicts to declare. Let's go to the next slide. Great, thank you. Let's begin with mental resilience. When we talk about resilience, we are referring to a person's ability to manage and cope despite experiencing significant adversity. Resiliency is a psychological and a social process that shapes how we as humans face challenges and crises. Mental resilience is something that we learn how to do over our lifetime. We learn in many ways, typically taking in from our environment ways to move forward despite challenges that we experience. Mental resilience involves tapping into ourselves, others around us, and other forms of support to both understand the challenge that is in front of us and to manage issues as they emerge in our lives. Although we know building mental resilience can support us moving through life challenges, sometimes some of us have so much resilience that it becomes harmful to one's health. The body may experience a process called weathering, where there is so much accumulation of cumulative and chronic stress that there's this wear and tear on the body, and this energy that is expended to face these challenges really overwhelms the body system and contributes to things like biological aging. Um, this is especially true when we look at broader conditions a person may experience in their life that are beyond individual control. This might be exposure to incidents of violence, um, employment layoff followed by an illness. It may be a cut in public funds for aging services, as several examples of potential challenges beyond an individual's control. Let's go to the next slide. Now let's talk about healthy aging, which refers to this lifelong process that encompasses all of the information, knowledge, skills, tools that we apply over our lifetime to preserve self and our functioning. And so what this looks like for a person in a community, an older adult in the community, healthy aging is really about freedom, independence, being worry-free, connecting with people that you love, and really kind of living your life with meaning. Healthy aging also implies that healthy aging begins long before older age. Let's go to the next slide. I'm a gerontologist trained as a social worker, and so we place a lot of emphasis on understanding the relationship between a person and their environment. On this slide, you see the different components of the person: the biological person, the psychological person, the social person, and the spiritual person. What we know is that place or environment may shape mental resilience and healthy aging, and it may do so in different ways. So I want you to keep this slide in mind as we continue to have our conversation about different aspects of healthy aging and mental resilience, and as we talk about the role that place in the environment plays in achieving health-related outcomes. Let's go to the next slide. It's important to note that we are always aging. To age means to be in a constant state of change, constant state of growth. For this reason, our discussion on healthy aging also takes us back to the beginning of our lives. So I'm going to suggest that we take on a life course lens as we discuss mental resilience and healthy aging. Let's go to the next slide. The question posed for this talk, and I'm going to spend a few minutes on this particular slide, is how do we design a community to support mental resilience and healthy aging? Let's review a quick story. What determines how long we all live? Is it what we do? Is it who we are? Actually, when it comes to predicting how long you'll live, your zip code is more important than your genetic code. Here's how this works. Meet Deb and Maria. They both have jobs. They are around the same age. They are both married and they both have 2 kids. Deb lives in A-Town, while Maria lives in B-Ville, less than 1 mile away. They're similar in so many ways, but here's the thing. On average, residents of B-Ville will die more than 15 years sooner than residents of A-Town. Why though? Because where you live is about more than just your address. It's really about your opportunities. For example, Deb and Maria's access to healthy options is really different. In A-Town, Deb's family is surrounded by healthy food options, including farmers markets, specialty shops, and grocery stores. The air in A-Town is cleaner and fresher, and there are lots of safe, clean parks where Deb can exercise and her children can play. A-Town has good public schools for Deb's kids and easy access to emergency and preventative health care. On the other hand, B-Ville has broken, badly lit sidewalks, and the parks are unsafe. The air is filled with truck exhaust from the nearby highway, and for food options, Maria's only choices are liquor stores, fast food places, or convenience stores. The schools in B-Ville are overcrowded and undersupported. And even Maria, and even if she could get her kids into better schools far away, she still needs to figure out how to get them there without access to a car. So for Maria, having to juggle so much to find healthy options can be an overwhelming source of chronic stress, which is a serious health risk factor, in fact, for all residents of B-Ville. Chronic stress drives health problems like obesity, diabetes, asthma, and heart disease. How did A-Town and B-Ville get so different, though? Well, in many cases, in cities and towns, the root cause was racial and economic discrimination. Over the generations, poor white people and poor people of color were pushed to less desirable parts of town where banks refused to lend money, businesses left, jobs left too, schools declined, and the neighborhood crumbled. Everyone who could move away did. And what's more, when communities like A-Town and B-Ville are so unequal, B-Ville isn't the only one that suffers, because it turns out that not only is your zip code a predictor of how long you live, so is the country you live in. Countries with the greatest income equality have the lowest life expectancy. So even Americans like Deb, who are white, insured, college educated, and upper income, will die younger than their peers in other countries. In fact, our life expectancy is 43rd in the world, and that number is slipping. In the end, our biggest health risk may actually be inequality, and extreme inequality hurts us all. So what do we do? Well, if we are going to be healthier, we just don't need to help the folks in B-Ville beat the odds. We need to change the odds for everyone. We have to build the power to make health happen in communities. From an equity lens, the strategies in A-Town and B-Town may be similar, or they may be very different, requiring differential use of resources. We can learn many things from this story in the contribution of place to healthy aging. But I'm going to raise the question, is place friend or foe? Let's go to the next slide. This is a slide of my childhood home in the middle. This is 3130 North 33rd Street. I grew up in Milwaukee in the inner city. And by all accounts, I grew up in a very challenging environment, but one that was filled with love, happiness, positivity, joy, connections, both within the community and external to the community. Let's go to the next slide. This is another look at 3130 North 33rd Street, according to the Area Deprivation Index, which measures social disadvantage. I grew up in one of the most socially disadvantaged areas in the country, surrounded by wealth. So the blue pockets that you see are toward the coast line in Milwaukee near Lake Michigan, and you start to see the blue on the left side going into the suburbs. Let's go to the next slide. I want to take another look at 3130 North 33rd Street. Milwaukee continuously ranks high on the list of worst places in the country to live and to be Black. Let's go to the next slide. So I want to pose a series of questions to folks here as we have this conversation about how do we design communities and what is the role of place and environment. Just think to yourselves, what do you think about 3130 North 33rd Street based on the 3 illustrations that have been presented? How do you imagine the people who live here? Are they all like me, faculty at universities? Are the people healthy there? What is the extent of exposure to risk and protective factors for people who live in that place? What are their outcomes? Are those outcomes okay? Who even determines that? How do we interrupt poor health outcomes in these places where we have and see very wicked problems? We are talking about older adults and aging and just thinking about yourself and your relatives. Would you live at 3130 North 33rd Street? Or would you place a family member in a facility or in a home at 3130 North 33rd Street? Let's go to the next slide. So let's talk a little bit about some strategies for building mental resilience. You can see the 6 strategies listed on the slide. The first is really, it's important that as we age that we stay connected. And there is something about social connectivity and being involved and engaged in our broader environment and being social beings that is important to activate. Ensuring that we are guided by purpose. Number 2, that we are operating with the level of intentionality. 3, that we are learning the lessons from our past, that we really think about what has worked as potential coping strategies when stressful situations come up. 4, what we know is that the way that we view the world impacts our experience. So staying hopeful, being open, being able to imagine new possibilities for oneself is really important to build this sort of a muscle of mental resilience. 5th, really to take care of yourselves, particularly folks who are caring for people with dementia. They tend to deprioritize their own health, and it's to their detriment and to the detriment of the care that they are providing to others. So take time to tend to your own needs and feelings. And 6, take action. Don't ignore problems. Bad things happen. It is important to think about what you need to do to make a plan and to take action. Let's go to the next slide. Let's also talk about some general strategies for healthy aging. Again, these strategies are just general strategies that we all should be thinking about. And these are no surprise to this community of folk. Really thinking about the role that nutrition plays in leading a healthy life, thinking about the role of sleep, physical activity, exposure to tobacco products, alcohol, and other substances, really maintaining regular doctor visits, and ensuring that one has strong social connections. Let's go to the next slide. So we discussed some individual things that folks can do to build resiliency and support healthy aging. My apologies if you can't read the slide, but what I wanted to do is talk a little bit about what I'm going to call more system level changes. Dr. Gogler certainly mentioned the important role of policy. And so where I want to kind of go with these next two slides is really for us to think from a structural lens. How do we design structural level interventions to support healthy aging and mental wellness? And the age-friendly communities is sort of one example of that, where there is an interest in destigmatizing age, really combating ageism, really training persons in all different sectors, whether it be the restaurant sector, the banking sector, on how to interact and to support persons who are aging. So there are age-friendly communities, there are dementia-friendly communities, but what we are talking about is building up the capital within community so that older adults feel supported and like they belong. Let's go to the next slide. Another effort that is really targeting the healthcare workforce, it's a program of the Health Resources and Services Administration called GWEP. There is this effort to think about how do we train healthcare professionals in hospital and primary care settings so that these spaces are age-friendly, and really promoting this idea of age-friendly hospitals, which has sort of like four concepts that when you speak with an older adult, that you really ask them what matters to them, and that becomes one focus, an important focus of the clinical exchange, that you focus on reviewing medications, that you talk about what we call mentation, or sort of mental wellness, and thinking about cognition, how folks are processing and thinking about things. And lastly, thinking about mobility. And so we see this effort emerging around the country to really move our healthcare workforce in a different direction. And so we can take these two efforts, one sort of inside the healthcare field and one kind of in the broader community field, as these sort of structural level changes that are being infused in places and environments to address mental resiliency and healthy aging. Let's go to the next slide, and that will be the last slide. Finally, some take homes. Prioritize yourself first. Two, wherever you are at, start where you are and know that every small step counts. I've been really polite during this presentation and left all the politics out, but I'm going to say your environment influences your health outcomes. And more importantly, you must be an active agent in modifying environmental conditions. So that's all I have, Dr. Cullen. Thanks for allowing me to chat with everyone tonight.
Wow, that was amazing and just incredibly insightful. Thank you so much, Dr. Cotton, for that. Last but not least, I'm very excited to welcome Dr. Derek Salisbury. So Dr. Salisbury is an assistant professor in the School of Nursing. He leads a National Institute of Health funded study in partnership with Moai Technologies, exploring if combining aerobic exercise with cognitive training that utilizes virtual reality will improve cognition. The treatment could delay the onset of Alzheimer's disease by 5 years and save an estimated $89 billion in healthcare costs by 2030 and improve the quality of life of those affected by it. So Dr. Salisbury, could you discuss the impact of aging on cognitive health and your exergame research, please?
Yeah, thank you very much for having me today and talking about this, in my opinion, a very exciting and important topic area. First, I just want to say I don't have any conflicts of interest as it pertains to anything I am talking about today. And I do want to acknowledge all of the participants and the staff that have helped out on the exergame study and the NIH for obviously providing the funding for this study. Briefly, to go over an overview of some of the topics that I'll be discussing here today. I think we're going to review cognition and some of the stages of cognitive decline that we see with aging and some of the neurodegenerative disorders that we've talked about that can lead to dementia. We'll talk about some of the risk factors for cognitive decline. Most commonly, we're going to focus on underlying Alzheimer's disease. We'll talk about the exergame study and the importance of exercise for healthy brain aging, and then some other tips from the Alzheimer's Association. So I think first, and Dr. Gogler did a great job of talking about dementia in general and some of the symptoms that are associated with it. And when we look at dementia, it's almost if you can picture in your head just a triangle, and at each corner of the triangle, you're going to have a symptom or sign. And one of those is going to be cognition. You're going to have another going to be impaired ability to perform your activities of daily living. And at the other side is going to be some of those behavioral and psychological signs and symptoms that you would typically see. So our research really focuses on exercise intervention for improving cognition to some extent or attenuating it in those who may have Alzheimer's disease. And when we look at cognition, I just want to make sure everybody's on the same page here. Cognition is going to be the process of acquiring knowledge through thought and exposures or senses. And when we look at cognition, the NIH will kind of have under its umbrella of cognition, we have what is called fluid and crystallized cognition. And fluid cognition is more looking at the ability to reason and deal with complex information that is around us. While the crystallized cognition is going to be knowledge that comes from past experiences or prior learning and past experiences. Within the fluid domains of cognition, you can see we have executive functioning, processing speed, attention, and memory. And executive function is a really important one. And executive function is a set of cognitive skills that allow you to plan ahead, allows you to follow multitask directions, and really stay focused despite any type of distraction. Processing speed is going to be exactly what it sounds like, your ability to process information in a timely manner. Attention is going to be one that you're choosing to concentrate on a relative stimuli and block out any distraction. Working and episodic memory, if we look at working memory, those are, you're able to use information without losing track of what you're doing. If you want to think about, if you ever played the game memory, with a child or something like that, that's really working on your working memory. And episodic memory is the ability to learn, store, and retrieve information about experiences in your everyday life. So with cognition and our fluid and crystallized, it's really important when we look at the context of aging, and this is healthy aging, Your fluid domains really tend to decline with aging, okay? And these aren't going to be rapid, maybe they probably won't be overly noticeable declines, but they will decline if you test them. But they are also more likely to be affected by biological processes, so some of the neurodegenerative disorders, and more positively impacted by interventions such as exercise. You're crystallized, and I think of this as related to language and your ability to language is going to potentially increase or be maintained through the aging process, but they're less likely going to be affected by some type of intervention. And once again, Dr. Gogler did a really good job of kind of talking about some of the terms of dementia a little bit on the course of it, but I just want to highlight here, when we look at some of the diagnoses and courses of dementia, the slide is really looking at dementia due to underlying Alzheimer's disease or probable Alzheimer's disease. And we often have that preclinical AD or preclinical state. You might hear this term, and this is basically looking at an individual who unknowingly has those biological processes, the amyloid plaques and the neurofibrillatory tangles that are developing in the brain 10, 20, maybe even 30 years before the onset of symptoms, but there is nothing going on with their cognition. Eventually, they might move into this stage called mild cognitive impairment. This is a clinical diagnosis where you're going to have objective cognitive impairment. It might be tested on a MoCA. It's a very common cognitive assessment that a clinician might use. But your functional decline, or there is no functional decline. You're still able to maintain your activities of daily living. Then we get into that dementia stage, which is, of course, irreversible. With the preclinical stage, you might also come across a term called subjective cognitive decline. And this is a little bit different than what we would see with normal brain aging, where we see an individual whose cognitive, that fluid domain may decline a little bit, but it's not really noticeable. In subjective cognitive decline, an individual might be thinking, okay, something's up with my memory. I feel some slip in my memory or other cognitive domain, but they would test objectively normal on a cognitive assessment. And I want to say about 11.5% of individuals over the age of 45 do report SCD. Mild cognitive impairment, this is another really important potential point for intervention. And this is kind of a tipping point in that teeter-totter. About 10 to 20% of people with MCI will in a year convert into a dementia stage, but some will just stay in that state or revert out of it, and we don't know why that is. But it is, in my opinion, if we're looking at the treatment and management of a dementia state, very, very important. But of equal importance is going to be, is there something we can do to hopefully best case scenario prevent it or attenuate the rate of the decline that we see cognitive wise. So this will kind of tie into this slide here. If we're looking at a preventative vantage point and really related to Alzheimer's disease, it's important to understand your risk factors. And if anybody understands, say cardiovascular diseases, those are much more commonly discussed and understood set of diseases, but you're going to see a lot of overlap between your Alzheimer's disease risk factors and your CVD risk factors. And we're talking about the ones that are potentially modifiable. And on this slide, it's really important to point out that physical inactivity contributes to roughly 21% or 1.1 million cases of these Alzheimer's disease and related dementia. And this is really important because exercise, which is the most common form of physical activity, has been linked to a 30 to 40% decrease in risk reduction for ADRDs. and a theoretical framework for why could exercise be potentially important in ADRD prevention. In red, those red circles, that was that kind of that symptom triad that we would see with dementia. And then in the green boxes, the risk factors. So exercise training, okay, we'll talk about some of the cognitive effects, but big picture, exercise is important through the lifespan in healthy aging as it pertains to cognitive function. It's important in improving cognitive function in kids. It is important in improving cognitive function in middle-aged and healthy older adults. We'll get into some of the Alzheimer's spectrum pieces as it relates to exercise and cognitive effects. But exercise is going to be really important for you to maintain your functional independence, particularly strength training. And if you look at some of the behavioral and psychological signs of dementia, you commonly see anxiety and depression. There are plenty of other ones, but exercise is a very, very important part in the management of anxiety and depressive symptoms. And lastly, the risk factors, okay, that we just talked about on the last slide. I like to tell our patients and research participants that exercise is almost like a poly pill. Okay, so if we look at lipids and glucose and hypertension, inflammation, for instance, exercise is like has antihypertensive effects, lipid lowering effects, has very potent glucose lowering effects and improving your insulin sensitivity, and is an anti-inflammatory. Hardest part, okay, it's much easier to take a pill than it is to meet your physical activity and exercise guidelines. Okay, so when we look at our study that I wanted to talk about today, the exercise study or exergame study, this is a concurrent aerobic exercise and cognitive training program that was targeted in people considered to be at risk for Alzheimer's disease. So these were the individuals who were in the subjective cognitive decline state, meaning that they reported a memory complaint. It had worsened in the last 2 years, but they tested objectively normal on a cognitive battery. This is just a very brief picture of the trial design. We randomized our participants on a 2-to-1-to-1 allocation ratio to either an exergame group, a cycling group, or a stretching group. They perform the activity 3 times per month or 3 times per week over 3 months, so over 36 sessions. And then we collected data at baseline and at post-test. When we look at the study, we started recruiting right prior to COVID. So we had to flip to a virtual delivery format. So we did the interventions. They were supervised, but we had to do them over Zoom. Okay, so looking at the protocol again, there's our exercise prescription, our cycling group, aerobic exercise only. They had moderate intensity cycling on a stationary recumbent cycle, 30 to 50 minutes per session. We progressed them in a safe manner. Each person had an individualized exercise prescription at moderate intensity based on the results of a baseline fitness test. The exergame group, they did the same exact cycling prescription. And on the next slide, we have a picture of what this looks like. But basically, they were playing an exergame. So on their bike, on the console, we had an iPad up there. And they had an Xbox controller in their hand that was navigating them through a virtual environment. And they were playing these cognitive games that you'll see here. And once again, it was matched to the intensity and the duration of the cycling group. The stretching control group did virtual range of motion and stretching exercises at light intensity, once again, matched to session duration of the exergame and the cycling group. And our outcomes that we were interested in, cognitive function, particularly the fluid domains, aerobic fitness. Okay, so walking-based field tests of cardiorespiratory fitness. We measured affective symptoms of depression and anxiety that I won't really report on here today. And as well, we also talked about or measured quality of life and their individual domains, particularly physical, psychological, social, and environmental quality of life. And here's our kind of the setup of the Xer game. You can see the individual there cycling on the bike. She has the controller, unfortunately, in her right hand, so you can't see the Xbox controller. We did sync it up to an Apple TV for picture purposes, but you can see the individual, and when they're cycling, as they pick up their cycling speed, they're going to move through this quote unquote city or small town, downtown environment. And on the right picture, you can see that circle. It's almost like your map. Okay, so you're the blue dot, and you're cycling through this town, turning through streets, and your goal is to reach that green dot. And when you reach that green dot, a new virtual environment will pop up, and these are your cognitive games. So this is an example of the cognitive games, and these cognitive games were selected based on the potential for ecological validity. Okay, we wanted to mimic potential tasks that these older adults might still be doing as part of their activities of daily living, such as, in this case, grocery shopping. So when they would get to the green dot, this picture on the left would pop up, and they'd have to memorize the shopping list. And as they're cycling through the grocery store, on the right picture, you can see the grocery cart there. They have to select the shape and color of what they had to memorize on their shopping list that disappears once they get into the grocery store. And the more correct items that they choose, the more points they get. If they're selecting the wrong items, their score drops. And over time, as they reach certain thresholds, the number of items that they can choose from in the store increases, and the potential items that they have to memorize increases. So not only were we, progressively increasing their exercise prescription to improve aerobic fitness, we were also looking to increase the cognitive stimuli. This is just looking at the feasibility of being able to do this in a virtual environment. I'm not going to take much time to go over this, but one of the craziest things we saw was our attendance was extremely high for an exercise, supervised exercise study. And it really shows that this telerehabilitation format was something that took away barriers for exercise that are commonly reported for urban, suburban dwelling adults, as well as rural adults, which weren't included in this sample. But travel barriers are very, very important, as well as access barriers. But overall, in summary on this slide, we were able to get them at their target exercise intensities, and they were able to exercise at the prescribed duration with no difficulty. And what were some of the preliminary effects? And if you can think back to some of the definitions of cognition, we talked about attention, executive function, and fluid cognition. We did see for fluid cognition, that's a summary score of all those individual domains that fall really within executive functioning. We saw significant within group changes for our exergame group in the orange, as well as the cycling only in the red. The control group did not significantly get better in fluid cognition. One thing that did stand out was the cycling only group improved significantly within the attention domain. Looking at the effects on aerobic fitness, you can see that the 6-minute walk test, this is one of the gold standard aerobic fitness tests that you would do in a cardiac rehabilitation or pulmonary rehabilitation setting. The goal of this test is to walk 100-foot walking track as fast as you can without running over 6 minutes. So the more distance you can cover, the better. And both groups saw significant within group changes, and these were actually considered clinically meaningful changes for older adults. So these individuals, particularly in the exergame group, they were able to improve their fluid cognition, improve their aerobic fitness, showing that this dual task training, doing the exercise with the cognitive stimuli, the cognitive tasks did not take away from their ability to maintain moderate intensity exercise and improve their aerobic fitness. And why is this important? Well, there's, as Dr. Gogler mentioned, there's several hypotheses for, the underlying Alzheimer's pathology. Well, one thing we've also come across is this cardiorespiratory fitness hypothesis that shows that individuals who have higher cardiorespiratory fitness have higher cognitive functioning. They also have less depressive symptoms. So, one of the things that we look at as an exercise or as an exercise physiologist is, okay, it's important to stay active, but let's try to choose activities that can enhance our cardiorespiratory fitness with the hopes of enhancing cognitive function or maintaining it throughout a healthy lifespan. So there's a lot of evidence out there that supports this cardiorespiratory fitness hypothesis. We found this in our study as well. And lastly, I want to end with some tips from the Alzheimer's Association for Healthy Brain Aging. It's kind of similar to what Dr. Cotton was talking about on his slide here. Breaking a sweat. Okay, so the importance of staying physically active and exercise. And if you can remember, physical inactivity is considered to be your most important, potentially modifiable risk factor for Alzheimer's disease. Hit the books, okay, stay educated, stay mentally involved. 3, don't smoke. 4, follow your heart. That kind of goes back to control those cardiovascular disease risk factors, okay, hypertension, dyslipidemia, your blood glucose levels, for instance. Heads up, okay, try to stay away from those traumatic brain injuries. Number 6, nutrition, fuel upright. Try to maintain a healthy diet. 7 is sleep. Okay, get those 6 to 8 hours, of sleep every night. Number 8, take care of your mental health. Number 9, buddy up, stay socially engaged. That's great to do with exercise. And 10 is stump yourself, okay? Stay cognitively active. That's where the cognitive training comes into play. And when I look at this list and look at the importance of exercise, well, exercise obviously is number 1, but how else does it relate to this? Okay, well, it can help with number 4, lowering your CVD risk factors, primary prevention of coronary artery disease. It can help you with sleep. It can help with your mental health by reducing your anxiety and depression. And then obviously, if you are exercising, you can obviously combine it with your cognitive training as well. And you're taking care of 2 of those tips in one session.
Wonderful. Thank you so much, Derek. And
Yeah.
that was really wonderful. And now it's time for our discussion. So we've gotten some really great questions from the audience, and our team here at the medical school has helped with filtering and kind of putting together some questions for me to pose for you guys. So I'm going to start with Joseph. Could you, there was a question about herbal supplements. Are there any herbal supplements that can help treat Alzheimer's or dementia?
The blunt answer is no. But I wanna provide context to this to some extent. When one looks at the scientific literature, herbal supplements have not shown any significant benefit on outcomes related to dementia progression. Now, my mentor, who my endowed chair is named after, Robert Kane, who was a world-renowned geriatrician, health services researcher, had this saying that always resonated with me. And I think it's apropos when we think about dementia and evidence, which is absence of evidence doesn't mean evidence of absence. And so what that means is there is a lot of ongoing research that is taking place that is showing a lot of exciting pathways to causes of dementia. I think one of the questions I noticed in the chat had to do with, I think, prenatal drug exposure or something. And So if you look at the actual really well-established risk factors of dementia, you saw Dr. Salisbury mention some of them. If you permit me, I'm going to show you a really great figure that I often refer to when I give community presentations on dementia. I apologize if you can't see this well. But this actually was from a very, very important study that came out in the Lancet several years ago. And it was an international team of scholars that more or less surveyed all of the available literature to determine risk factors related to dementia. And one thing that's really important is you heard Derek talk about modifiable risk factor. This international team determined that 40% of dementia risk is potentially modifiable. That actually is not insignificant. That's pretty significant. So there clearly is a pathway to risk reduction in dementia. Now, what will that entail? It likely is going to entail a life course. And again, related to what Dr. Cotton was alluding to, a public health strategy to really reduce dementia risk. It will include a heavy emphasis on those cardiovascular risk factors that Dr. Salisbury talked about. It will necessitate and include an emphasis on social engagement, reducing social isolation and loneliness. It will also include a number of other risk factors that are emerging in the literature. For example, environmental stressors that Quentin was talking about. There's some suggestion, for example, that air pollution may drive dementia risk. Hearing loss you see here. Again, and at first glance, why would hearing loss be associated with dementia? Well, if we think about cognitive health is really linked to stimulation in one's environment, socially and otherwise, if hearing loss is not managed from midlife and beyond, you can see how that could potentially adversely affect cognitive health. So I don't want to totally dismiss out of hand herbal supplements, other nutritional approaches that may offset dementia risk. Right now, the evidence isn't great. And quite frankly, if one actually looks at how some of these herbal supplements are promoted, it doesn't give one a whole lot of confidence that, in fact, these are probably going to be strategies that can help with dementia risk. However, a multifaceted life course strategy that focuses on cardiovascular management, as Derek was talking about, that focuses on social engagement, that also focuses on cognitive stimulation together, that likely is probably a very potent approach to modifying our dementia risk. And I'll take it one step further, understanding social determinants of health, as Dr. Khan was talking about, and their contributions to dementia. It's a promising area of research. I think will continue giving us insights as to what we can do, how we can modify our risk over time. And hopefully the modifiable risk bubble will continue to increase over time.
Thank you so much. And I'm going to have to remember that saying by your mentor that absence of evidence isn't the same as evidence of absence, because that's an important thing to think about also in psychiatry and in my field. Thank you so much. Next question is for Quentin. So Quentin, if the US is 43rd in life expectancy, who are in the top 5 and what are they doing differently?
That is a great question. I can't tell you off the top of my head without pulling up my chart, but what I can tell you is there are very specific things that we see in those countries. We can begin with basic universal healthcare plans. We can think about income in those countries. We can think about diet in those countries, and we can also think about physical activity. And so some of these things are really ingrained in the social structure that we see in terms of how healthcare is administered in those countries. And there are just other things that we see that relate more to lifestyle regarding physical activity and nutrition.
Fantastic. Thank you. Derek, question for you. How do antidepressants impact the brain cognition in aging?
So from a cognitive vantage point, the direct mechanism of action really isn't understood. The theoretical vantage point, and it kind of goes with even anxiety in general. If I look at it and I tell some of our participants this: if we're going to test their cognitive function, we can have them in an anxious or a depressed state. Okay. And oftentimes we have to exclude them. But I think the important part is really if you are able to control your depressive symptoms with any type of those medications, you are going to have the potential to see your cognitive improve or your cognition improve.
That is helpful. And Joseph, did you have anything to add to that?
That's an interesting question. We certainly know, for some period of time, it was always thought depression was more of an outcome of Alzheimer's and dementia. And it kind of makes sense, doesn't it? If one is formally diagnosed with Alzheimer's and dementia, you would expect, to some extent, that depressive symptoms may increase because of that. However, good epidemiological research has emerged over the years that really has, I think, disentangled the temporal relationship between depressive symptoms and Alzheimer's, where in fact, depressive symptoms, the symptomatology is certainly a risk factor for later life dementia. And it kind of makes sense in that if one is depressed, one will probably be less likely to engage in many of the healthy lifestyle behaviors that Dr. Salisbury had discussed, and is probably at risk for a number of other negative lifestyle factors that could also contribute to dementia. One thing really to emphasize here, and I think we as scholars sometimes miss this because we tend to be so focused on this strategy and this intervention and identifying this singular risk factor, is in fact, all of these risk factors are highly interactional. They likely combine in very complex ways to contribute to dementia risk. So that, number one, is very important. And number two, I don't think we know very well what would, say, for example, long-term use of antidepressants, will that actually contribute or perhaps maybe mitigate risk for dementia? I mean, it could be one or the other. I don't think we really know that answer very effectively. And I think you could make a compelling hypothesis or case for one or the other. Maybe managing depression effectively and using long-term, and maybe Dr. Cullen, you might have more insights than I would, but managing depressive symptoms for over time might actually potentially reduce risk. We saw that, for example, with admittedly, it's not depressive symptoms, but use of, for example, hypertensive medications or other medications to manage cardiovascular risk, that in fact seems to have a potentially beneficial effect in offsetting dementia risk too. So again, much work to be done to answer some of these questions.
And I think another piece to add to this is when we look at just aging in general, there's a couple trains of thought with this, but it's one thing to live a long life, but how many of those years can we spend living in quality? And there's a lot of research out there that shows if you can reduce anxiety and depressive symptoms, okay, that's associated with improved quality of life. Okay, so that's another thing that put into this puzzle too is, yeah, we have the Alzheimer's piece and risk factors, but there's also the quality of life that falls into this realm too.
Yep. So doing what we can to maximize that when possible in every single way.
Yep.
Yeah, including addressing depression and
Yeah. Now, not to Dr. Cullen, not to disparage the field of psychiatry, of course, but one of the issues, you heard me allude to this in my talk, that's been a real problem in getting at this issue Derek talks about, quality of life for all of us, but also quality of life if we're living with dementia, is the inappropriate use of antipsychotics to manage behavioral issues in Alzheimer's. And really, the use of antipsychotics should only happen in very limited circumstances for people living with dementia. For example, if one is a risk to themselves or others, if one is inconsolable, those kinds of scenarios. And You know, a couple of weeks ago, I was actually interviewed on Sirius XM. They apparently have a psychiatry channel. I didn't realize this. And the host actually had a show, and they wanted to focus in this case on basically making decision to admit a loved one into a nursing home. And they had callers. And one of the callers was a woman from Tennessee, actually. And her mother was 91 years of age. And her challenge was her mother was the medication regimen that that her physicians were recommending was not being maintained in the assisted living facility. Yes, that's an issue. But then she started listing the medications her mother was on. Again, this is a 92-year-old woman. She was on Seroquel. She was on Lexapro. She was on Namenda. And for those of us that are steeped in geriatric principles, the question I have is why? And how can that be actually beneficial for this woman at her age in this context? I mean, again, to me, that is a symptom of often how we're addressing symptoms of dementia in ways that aren't always appropriate. Non-pharmacological approaches should be frontline.
Great, thank you. Question for Quentin. Are you aware of any research currently being done on dementia with a specific focus on Latino immigrants?
Yes. Perfect question for me. What I want to know is there a specific question or topic within the question that the person wants to know? Like, do you want to know about community design interventions? Would you like to know about types of interventions that have been effective? So the answer is yes. But I could
If you
answer if there's some more
I don't have
specificity.
that. Maybe they'll chime in, but while we're waiting, could you say if you have some information about types of interventions that are effective for Latino immigrants, that would be a great place to start.
Yeah. So what we know is there is an extreme amount of diversity. What we see happening in the literature right now is an increase in really both intervention science and implementation science. There is significant interest in culturally adapting or culturally tailoring programs for the Latino community. And so, what we see right now is the translation of evidence-based interventions for Latino populations. And this could be for respite care. This could be for training caregivers that are volunteers in the community or family members. This could be adapting all sorts of interventions. There are studies that are looking at sort of modality of delivery, meeting in person versus virtually versus over the telephone. So I think that this is an area that certainly over the last 15 years has gained a lot more attention and a lot more traction. And I think that this is an ongoing and really kind of like a hot button issue. We have seen particularly the stubborn disparities exist among racial and ethnic populations. And we certainly have seen national calls, particularly thinking about the role that mechanisms play. Do the mechanisms, what's in the secret sauce? Those factors that underpin programs, do they operate differently in racial and ethnic populations? And sometimes the answer is yes, sometimes the answer is no. But I think that this certainly is an area where we have seen lots of interest.
Thank you. So helpful. Great. Does anybody this is a question for any of the speakers. Anyone have thoughts on the benefits of using a sauna for aging and Alzheimer's? It's okay if you don't know.
Again, I mean, there are no studies that I'm aware of that have looked at a sauna and saying, it'll help you age in a healthy way or reduce your dementia risk. However, let's think about some of the risk factors we talked about. Depending on how you use a sauna, I know many people use saunas in conjunction with others. It might be a means of socialization. When we talk about cardiovascular risk management, often using a sauna is associated and are utilized to reduce stress.
Mhm.
I would say a sauna would not be a bad thing and would not be something I would say you shouldn't do in order to age in a healthy, beneficial way. Would I say putting a sauna on would be a key piece of the regimen to brain health as we get older? I probably wouldn't go that far, but one could definitely see the many ways and potential benefits of a sauna in order to age well.
Mhm. One of
Yeah,
the take care of ourselves.
Yeah, I will say this. I mean, I don't know if it requires an MD or PhD to recommend to you how to live, age well, and have brain health. It probably will require certain nutritional approaches, as Derek talked about, regular exercise, all of those things. Often the trick is how can we do it in a way that is sustained and enjoyable. I mean, that's the key trick to so much of this. The key trick really to much of chronic health disease management as we get older. I mean, one game I could recommend for anyone to be cognitively stimulated is playing chess, right? I mean, it requires multiple moves ahead of time in order to do well. Now, do we want to play chess is the other question. Some of us do, some of us don't. And there are just a whole list of other potential ways we can live and live with a healthy brain and age well. It's a matter of finding that right combination that is tailored to our needs, culturally tailored to what we may be interested in and be willing to do.
Yeah, I think Joe absolutely hit the nail on the head there. Even from a physical activity nutritional vantage point, you can have all the recommendations you want in the world.
Yeah.
And if you don't find any satisfaction in it, there's a reason why there's such low compliance for people meeting those physical activity guidelines for Americans. It's 20% on a good day meet those numbers. And the best advice that I would give from a lifestyle vantage point is you have to find something that is going to be fun and enjoyable, because if it isn't, it will not be sustainable. A lot of this stuff as it pertains to risk factor mitigation is I in the context of exercise and physical activity, I say, it's got to be a lifelong endeavor. Okay, it can't be just for 12 weeks because that's just a little band-aid to put on it. Otherwise, if it's not something that's sustainable, you just revert back to those old habits.
I
And that,
also just wanted to add that we are not at the point where we can unpack the myriad of variables that comprise the potential protective factors against cognitive decline and neurodegeneration. We aren't there yet. And I don't know if we ever will be. I think that there is such a level of complexity, and so it's sort of like, what food should I eat, right? What
Yeah.
specific vitamins should I take? What exercise works best for me? And so these are really complicated issues that the science has not been able to tease out as a singular variable.
Yeah, and that's the hope with precision medicine, right? And we're not that's not even getting at the genetic component to some of this stuff either. That's just a whole nother ball of wax to try to tie in.
thank you. And in spite of those kind of caveats, could any of you comment on maybe ways that women can be thinking about their health as women approaching the perimenopausal or menopausal stage? We're getting different kinds of messages, importance of exercise, but is it okay? Is walking good? Is it important to be more vigorous exercise? Is it more important to shift over to just weightlifting, heavy weights? And what about hormone replacement therapy after menopause? What should women be thinking about in this, given the current state of knowledge to prevent, to protect their brain?
Yeah, I'm not an expert on the hormonal replacement therapy as it pertains to Alzheimer's. Estrogen has protective effects really on the vasculature and some of the CVD risk factors. There is a reason why when we look at incidence of heart disease across the lifespan, generally men have lower risk than women compared to the time menopause hits and then it flips. Okay. Estrogen has a really important cardioprotective role on the inner lining of your blood vessels in particular. That's important in your for cerebral blood flow. And when we look at your brain, it isn't it's not an organ that has reserves of energy sources to supply metabolic needs for the brain. But there are risk factors associated with hormone replacement therapy. Breast cancer is a risk factor, clots to some extent, which are going to increase risk for stroke, just to name a few. But when we talk about lifestyle and exercise, strength training is really important in women's health, in my opinion. Just to help maintain muscle mass with aging, it's going to be really important in maintaining bone mineral density that you see decrease at the postmenopausal state. So resistance training, in my opinion, is a vital piece to tie in. There are studies that show that it can enhance cognition during the aging process. I focus more on the aerobic because there's a lot more studies on aerobic exercise and resistance training. And that goes back to the point, just because it hasn't really been fully shown yet doesn't mean it's not going to happen. With the aerobic exercise, if you're a believer in that cardiorespiratory fitness hypothesis, those high intensity interval training that's the best way to improve your cardiorespiratory fitness. But not a lot, there's pros and cons to this. You don't have to exercise as long, but it's harder. It really comes down to the end of the day. If you're going to exercise aerobically, I'd recommend to be at least moderate intensity, tie in the strength training. 2 days per week is going to be important, but you want to choose activities related to exercise that fit things that you want to do and allow you to find some enjoyment in it, because not everybody likes to exercise. But we need to find something that's sustainable.
Thank you. Joseph, I saw on your beautiful figure you showed us about the risk factors that alcohol use, especially heavy
Yes.
alcohol, accounts for 1%. What about marijuana? We now
Unknown. Yeah, really
No.
great question, Catherine. Unknown. I would think, well, one thing that's interesting with cannabis use, and I've seen a few studies to this effect, not many though, and certainly not in larger scale human trials. There's been some suggestion, for example, of use of cannabis to maybe help with reducing agitation, anxiety, some of the behavioral symptoms of Alzheimer's disease and related dementia. Now, whether cannabis use will have what are the long-term cognitive effects in late life, that remains to be seen and is unknown. Again, one could hypothesize null effect. One could hypothesize potentially damaging effects. But one could maybe also see potential positive pathways too. I wouldn't be willing to rule out any of those.
Yeah, we're kind of in a similar boat at the earlier end of life as well. There's
Right.
still with respect to marijuana in the brain and young
Yes.
people.
Yep.
So it's kind of an urgent thing we need to know more about.
And from a basic science vantage point, you can make an argument like this is classic in a supplement industry too. Okay, you can target a lot of these pathways just individually. What's that going to pan out to? We really don't know yet.
Did you have anything to add, Quentin?
No, sorry, I'm typing up answers in chat.
No,
Oh,
that's
thank you.
good.
Thank you for doing that. And yes, we will be available. We'll be able to continue to respond to some of the unanswered questions. I saw that some people sent a message that they didn't get the Zoom recording emailed. So I'm sure that our wonderful team will be sending out a communication with this recording hopefully tomorrow, and as well some follow-up communications. So I think what I'd like to do is go ahead and wrap up. I just want to thank the panelists for your time and sharing your insights into the importance of meaningful connections and activities in the later stages of life, promising treatments for dementia, and prioritizing quality of life and brain health during this phase of development. We also want to thank you, our wonderful audience, our participants in the Mini Medical School, for joining in this series, and thank you.
Can I make one quick last announcement here, Dr. Cullen?
Yes.
For those of you interested in getting more information, education, and resources as it relates to living with dementia, caring for someone living with dementia, whether you're a family member, loved one, or healthcare professional, please join us on June 1st. This will be the 17th year we've held the Caring for People with Memory Loss Conference. It's all about tools, resources, and education as it relates to caring for someone with cognitive impairment. We'll have free food. It's a free event. We hold it at McNamara Center. It'll be June 1st, all day from 8:30 to 4:30. Also, we have a hybrid Zoom option as well. For more information, see z.umn.edu/memory loss conference. And that's also where you can register and see our great presentations we'll have this year. So hopefully you can join us. Thanks a lot, Dr. Cohen.
Yes, thank you.